Hello students, welcome to today's class. I am Bernisha, lecturer from Emmanuel College of Pharmacy. Today we are going to discuss about another topic from pharmacotherapeutics, that is polycystic ovarian syndrome. Nowadays this polycystic ovarian syndrome is otherwise known as polymetabolic ovarian syndrome. In this video, we are going to briefly discuss about what is polycystic ovarian syndromes, what are their etiology, pathophysiology, along with their clinical manifestations, pharmacological management. Okay, students, let's get into the video. First, let's see what is polycystic ovarian syndrome. The polycystic ovarian syndrome is a heterogeneous disorder which is mainly defined by the combination of signs and symptoms of androgen excess and ovarian dysfunctions. Usually, there is a clinical manifestation of oligomenorrhea, subfertility, hirsutism, as well as an acne. So these are the combination of both the androgen excess as well as the ovarian dysfunctions. Totally, it is known to be the polycystic ovarian syndrome. So it is mostly a hormonal imbalance and also a ovarian dysfunctions. So, polycystic ovarian syndrome is a heterogeneous disorder which is the combination of androgen excess and an ovarian dysfunctions with a clinical manifestation of oligomenorrhea, subfertility, hirsutism, and acne. So, next, the polycystic ovarian syndrome also has some other polycystic ovary disease, functional ovarian hypoandrogenism, ovarian hypothyrosis, scleroscystic ovary syndrome, and Stenin-Levithinol syndrome. These are the some of the names which was given to the polycystic ovarian syndrome. Nowadays, it is also termed as polymetabolic ovarian syndrome. So it is first time it is discovered in 1935 by the American gynecologist Irving Epstein and Michael F. Levithinol. So it is known to be the Stein-Levithinol syndrome. Next, it is the most common endocrine disorder of women of reproductive age group. Usually, nowadays, the polycystic ovarian syndrome is the most prone diseases among the women of the reproductive age. Usually, in 195% of the people have this polycystic ovarian syndromes. So here, prevalence varies among the races and ethnicities. If it's in USA, it's about 4 to 12 percentage, and in European studies, it will be about 6.5 to 8 percentage. Northern Nigeria, it's around 12.2 percentage, and Benin, it's around 27.6 percentage. These are the prevalence of polycystic ovarian diseases in the races and ethnicities. Next will be the introduction for again and another introduction for the polycystic ovarian disease. In the first itself, we studied that the polycystic ovarian syndrome is a combination of excess of androgen as well as the ovarian dysfunctions. So it mainly affects the people at the premenopausal stage and the onset of most often to premenopause stage. It's mainly associated with clinical, social, and psychological problems. Usually, the peoples with lower body weight, insulin levels, restore fertility, restore regular menstruations, treat hirsutism or acne, and prevents the complications. Once the people manages this body weight, insulin levels, fertility, menstruations, hirsutism, acne, they can easily manage this polycystic ovarian syndrome. Etiology of polycystic ovarian syndrome. Usually, the major causes for the polycystic ovarian syndrome may be genetic basis. Sometimes it may be suspected as autosomal dominant, such first degree male symptoms. Sometimes it may be of twin studies and dysregulation of CYP11A gene. Some of the genetic basis also leads to the polycystic ovarian syndrome. Upregulations of other enzymes in androgen synthesis pathway, insulin receptor gene on chromosome 19p13.2, decreased sex hormone binding globally. So these are some of the genetic bases that being suspected to be the etiology for the polycystic ovarian syndrome. Other than that, the genetic conditions, there will be the predisposing factors such as family history of PCOS. If our parents have the PCOS systems, they will be have the family history of PCOS. High maternal androgens. If the body has high maternal androgens, there may be leads to the PCOS. Next, onset of type 1 diabetes mellitus before menopause, insulin resistant, obesity, drugs example, valproate. So these are the other predisposing factors. That means other than the genetic factors, there will be like family history or high maternal androgens, onset of type 1 diabetes mellitus, insulin resistance, obesity, some of the drugs we have used like valproate. So these are the some other causes. Next will be the physiology of menstruations. We know that after the hypothalamus, there will be the gonadotropin releasing hormones from the anterior pituitary. Due to that, there will be the secretion of luteinizing hormones and follicle stimulating hormones in the ovaries. After that, the ovaries releases the estrogens and progesterone. Thus, due to this, there will be the menstruations on the every 28 days. Next will be the pathophysiology. Here, hypothalamus activates the pituitary gland where they produces the gonadotropin releasing um, hormone. Then, after that, there will be the increase in the luteinizing and follicle stimulating hormones ratios in the ovaries. If there is an increases in the androgen levels in the ovaries, sometimes if it produces, there will be the increases in the estrogen and progesterone level. It may lead to menstruation. Sometimes it may have the increases in the androgen levels or abnormal lipid profiles in the adrenal glands. It may lead to some of the skin conditions like hirsutism, acne, acanthosis nigricans, etc. When it is may leads to the abnormal lipid profile, the adipose tissues, it may leads to insulin resistance, follicular atresia, which may further leads to anovulations and amenorrhea. If there is an increase in the estrone level for non-cyclic purposes, the uterus may leads to endometrial hyperplasia. So these are the pathophysiology of polycystic ovarian disease. Actually we know that it is the combination of excess androgen as well as the ovarian dysfunctions. So from that increases in the androgen level shows the hirsutism, acne, acanthosis nigricans, as well as when there is an increases in the estrogen levels in so these are the pathophysiology of polycystic ovarian syndrome. So, what are the clinical features of polycystic ovarian syndrome, which may includes the clinical manifestations? First will be the features of menstrual dysfunctions, which may lead, which can be seen in irregular periods or irregular menstrual cycles. Both will be the irregulars as well as the abnormal menstrual cycles. And the next will be the features of hyperandrogenism. Hyperandrogenism is the increase in the excesses of androgen hormones in the body, which may lead to hirsutism, acne, androgenic alopecias. Hirsutism means there will be the increase in the hair growth in the face, etc. Acne as well as the androgenic alopecias, there will be the high hair loss. And other endocrine dysfunctions like insulin resistance, diabetes mellitus. So this insulin resistance may further leads to the diabetes mellitus. Next will be the obesity, acanthosis nigricans. Sometimes it may also leads to infertility or some of the miscarriages during pregnancies. And next will be the obstructive sleep apnea, metabolic syndromes. It may also completely changes the metabolism of our body. And other than that, it also shows some endometrial neoplasia. Some of the endometrium of our uteruses can also get some of the destructive problems. Diagnostic criteria of polycystic ovarian syndrome. So the diagnostic criteria for the polycystic ovarian syndrome mainly includes the Rotterdam criteria. So based on 2023, to include two out of the following three, they have to give the conditions for the polycystic ovarian syndrome. So if an individual is suffering from any two of these three, they may be considered to be the persons with polycystic ovarian syndrome. The first will be the oligo or anovulations. Next will be the biochemical signs of hyperandrogenism, and the next will be the polycystic ovaries. So if a person is having both the polycystic ovaries and the hyperandrogenism, they may have diagnosis of the polycystic ovarian syndrome. So the next will be the AEPCOS based on 2009 category. So based on the 2009 category, it will be around hyperandrogenism. It may include hirsutism and the hypoandrogenemia. And the next will be the ovarian dysfunctions, which may include oligoanovulations or the polycystic ovaries. It may some of the exclusions of the other androgens or excess related disorders. So based on this 2009, it may also comes under the polycystic ovarian syndrome. So it changes from PCOD to PCOS, where it includes the hyperandrogenisms, hirsutisms, and hypoandrogenemia. So it along with the ovarian dysfunctions, it includes oligoanovulations or the polycystic ovaries. And exclusion of the other, it includes androgen excess or excess of androgen related disorders. Next will be the differential diagnosis. Along with that, there will be the use of biochemical screenings. So some of the hormonal tests are taken during the differential diagnosis. It includes hypothyroidism, hypothyroidism, hyperprolactinemia, hypogonadotropy, hypogonadism, primary ovarian failure, acromegaly, late onset of CH, androgen secreting ovarian tumor, androgen secreting adrenal tumor, Cushing syndrome, and exogenous androgen use. So it mainly includes the diagnosis of the hyperthyroidism and hypothyroidism along with hyperprolactinemia and hypogonadotropic hypogonadism. So if there is any changes in the hyperprolactinemia and hypogonadotropic hypogonadism, it may lead to some of the excessive secretions of estrogen and progesterone hormones. So based on it, during the differential diagnosis, we can easily calculate the hyperprolactinemia and hypogonadotropy hypogonadisms. Along with if there is any primary ovarian failures, if there is a process of anovulations or missed ovulations, so there will be some of the primary ovarian failure conditions. So these are some of the differential diagnosis which is taken during the PCOS conditions along with the 2013 and 2009 criteria. So next will be the investigations. What are the investigations and what are the tests were taken during the diagnosis of the polycystic ovarian syndrome? So it includes FSH and LH. So the follicle stimulating hormones and the luteinizing hormones are the basic hormones which is used, which helps in the regulation of the menstrual cycle. Once, if there is any abnormals or any other misleading of the um, normal values, so it may lead to the polycystic ovarian syndrome. Next will be the testosterone hormones level test, thyroid function test. If the person having the hyperthyroidism conditions, they may also have the they may also have the um, they may also have the possibility of having the polycystic ovarian syndrome. Next will be the serum prolactin test and blood sugar test. Usually the blood sugar test is taken to identify the insulin resistance of our body. Next will be the fasting lipid profile test. So the fasting abdominal lipid profile also helps in the um, helps in the finding of the polycystic ovarian syndrome. Next will be the DHEAS and 7-alpha hydroxyprogesterone and cortisol test. So next basic investigation includes radiological tests. So it shows the ultrasound scan, CT scan and MRI scan along with histology, that will be the endometrial biopsy. So while taking the scan of an uterus, we can easily find out the polycyst present on the ovaries. If there is any presence of polycyst on the ovaries, it may shows that there will be the polycystic ovarian syndrome. So next will be the histology. So in that histology, when they were taken about the endometrial biopsy, so the outer layer of the uterus has been taken and the tissues were biopsied to get the test results for endometriosis. So these are the investigations we are taken to um, diagnose the polycystic ovarian syndrome. Next will be the treatment. So what will be the treatment, which includes no universal treatment for the PCOS is available. So it is mainly individualized treatment. So there will be some of the women's goals, and also we have to treat the severity of symptoms. So first the modalities includes conservative, medical and surgical. There are three types of treatments which is involved in the treating of polycystic ovarian syndrome. So first, mainly it is individualized based on the women's goal as well as the severity of symptoms. So first will be the conservative treatments. So it is fairly we have to regulate the menstrual cycles from 8 to 12 menses per year. So next will be the mild hyperandrogenism. See if there is any abnormal values of the androgen hormones in the body, so we have to first take care of it to maintain the hyperandrogenism. So next will be the encourage of weight loss. So maintain the proper weight will be the major thing in maintaining the PCOS. And next will be the diet modifications along with exercises, periodic screening for dyslipidemia as well as the diabetes mellitus. We have to maintain the insulin resistance, thus we can probably maintain the diabetes mellitus. So next will be the medical management. So medical management mainly aims to lower the insulin levels. So once we have maintained the insulin levels, it may we can easily maintain the blood sugar level as well as the body weight. And the next will be the restore regular menstruations. So during this PCOS condition, there will be the irregular menstruation or missed periods. So we have to first restore the regular menstruations, and next we have to restore the fertility. Along with we have to treat the hirsutism or acne, and we have to prevent the endometrial hyperplasia and the endometrial cancer. So first we have to prevent the endometrial hyperplasia, or else it may further prone to the endometrial cancer. So these are the treatment. First we have to maintain the non-pharmacological management. Then we have to move on to the pharmacological management. During the non-pharmacological management, we have to maintain the body weight, restore the regular menstruation, restore fertility, treat hirsutism, as well as we have to lower the insulin levels. Next will be the medical treatment. So it includes some of the medicines. So restoration of ovulation or menstruation. For restoring our menstrual periods, we have to take in the combined oral contraceptive pills. So while taking this combined oral contraceptive pills, it may suppresses the gonadotropin release, and thus it reduces the androgen levels and induces the regular menstrual cycles. While we are taking this oral contraceptive pills, it will suppresses the gonadotropin release as well as the reduces the androgen levels in the body. Thus, it induces the normal menstrual cycles, and also cyclic progestogens. So, cyclic progestogens are also a combined pills which is contraindicated. Sometimes you have to take in with the proper prescriptions of a medical practitioner. So next will be the intrauterine progesterone devices, that is IUS or implants. And the next will be the insulin sensitizing agents. So insulin sensitizing agents are also plays a major role in the medical treatment for PCOS. And the next will be the insulin resistance and hyperinsulinemia. So to treat this high insulin resistant and hyperinsulinemia, we have to first take in the metformin. Metformin will be the most prone uh, medicine which is taken to treat the insulin resistance. So this metformin mainly improves the peripheral insulin sensitivity by reducing the hepatic glucose production, and it also increases the target tissue sensitivity to insulin. Thus, it also decreases the androgen levels and helps in the spontaneous ovulations. And along with this, we have to take in the thiazolidinedione compounds. The thiazolidinedione compounds plays a major role in improves the entry of glucose into the muscle and fat and suppresses the hepatic gluconeogenesis. So while it suppresses the hepatic gluconeogenesis, thus it prevents the storage of glucoses or prevents the storage of body fats in the extra muscles. Next will be the treatment of infertility. To treat the infertility, they have to take clomiphene citrate, tamoxifen, and clomiphene plus metformin, gonadotropin along with HCG and assisted reproductive technologies. Once if they have PCOS, they may also have some sub-infertility problems. They are not to be continued as an infertility patients, but they have some of the infertility issues. So to treat that infertility issues, they have to take clomiphene citrate, tamoxifen, clomiphene plus metformin, or along with the gonadotropin hormones with the HCG. Next will be the treatment for hirsutism. So it also includes the combined oral contraceptive pills which lowers the androgen levels and estrogen component increases the SHBG. Next for this we can easily take eflornithine hydrochloride. Eflornithine hydrochlorides along with gonadotropin releasing hormones and agonists, anti-androgens like spironolactone, cyprotin acetate and flutamide, 5-alpha reductase inhibitors, example finasteride, and hair removal, depilations and epilations. So we know that hirsutism is a major problem of having excess of hair growth. To remove the hair growth, we have to take eflornithine hydrochloride, gonadotropin releasing hormone agonist, anti-androgens, and cyprotin acetate, 5-alpha reductase inhibitors, hair removal, depilations, and the epilations. Next will be the treatment of acne. To treat the acne, we have to take combined oral contraceptive pills, topical retinoids, topical benzoyl peroxides, topical and systemic antibiotics, and isoteritinone. So these are the compounds which is used to treat the acne, which is the major symptoms in PCOS. So the alternative medicines for the treatment of PCOS includes acupuncture. So sometimes it may helps to regulate the menstrual regulations, which decreases the body weight. Sometimes it may also reduces the headache and improves the mood. Next will be the myoinositol. So it also promotes the proper insulin utilizations in the body, which balances the ovarian hormone functions, regularizes the menstrual cycle, as well as the improves fertility. So other than that of the combined oral contraceptive pills, we can also take this myoinositol along with the acupuncture techniques. While taking the myoinositol, which may increases or regularizes the menstrual cycle, thus it increases the fertility, and thus it also balances the ovarian hormone functions and promotes the proper insulin utilizations. Next will be the surgical treatment. The surgical treatment will be the last option to treat in PCOS. So mainly it includes ovarian wedge resections. They have to correct the ovaries through laparoscopic surgery. and next will be the oophorectomy. So oophorectomy means if the symptoms are really severe, they have to remove the ovaries. That will be the very rarely done procedure while treating the PCOS. And the next will be the laparoscopic ovarian drilling, that includes laser electrocautery and multiple biopsy. While doing usually the laparoscopic techniques for done while they have the clomiphene resistance, while the patients are clomiphene resistance, and they have what will be the mechanism, the mechanism for the irregular periods were unknown, and they may be due to the destructions of androgen producing stroma. So due to these conditions, they have to take they have to do this laparoscopic surgeries in the ovaries. Next, so these are the medical managements which is used to treat the polycystic ovarian syndrome. So in this video, we have learned about what is polycystic ovarian syndrome. So the polycystic ovarian syndrome is nothing but it's the combination of both the excessive androgen secretion as well as the ovarian dysfunctions. So it is the hormonal and the menstrual abnormalities. So it may be associated with the short or long-term complications. Usually it involves the complications such as clinical laboratory as well as the radiological methods. The treatment depends on the need of the patients and severity of symptoms. Usually the treatment may be of the conservatives, medical as well as the surgical. So the polycystic ovarian syndrome is the most important endocrine disorders that mainly affects the females in their reproductive age, which may lead to the serious complications like infertility. These further studies are needed to determine the exact etiology of PCOS, methods of prevention, and proper management. Okay, students, I hope you all have completely learned about the PCOS. Let's see in the next class with another topic. Thank you.